Hello everybody, my name is Dr. Amit Shah. I'm a consultant medical and hematological oncologist based in East Midlands. And today I'm going to do a case study about thyroid cancer in a 35-year-old Chinese male. This is a study presentation for MDforLives. So thyroid cancer is a disease that begins in your thyroid gland, located over the larynx or voice box. The gland wraps around the trachea or windpipe and produces two hormones, thyroid and calcitonin, which it secretes directly into the bloodstream. Inside the thyroid gland, follicular cells make thyroid hormones, which your body uses to increase energy and raise body temperature. Thyroid cancer occurs when there is a change in DNA inside the thyroid cells, causing them to grow uncontrollably and produce a lump, though it's uncertain what creates this DNA change. Symptoms of thyroid cancer include swollen glands or a painless lump swelling in the front of the neck, though only 1 in 20 lumps are cancerous. A sore throat or persistent hoarseness, difficulty swallowing. The four main types of thyroid cancer are papillary carcinoma, which are 8 in 10 cases. This mostly affects middle-aged women. Follicular carcinoma, which is 1 in 10 cases, again affecting mostly middle-aged women. Papillary and follicular carcinomas are known as differentiated thyroid cancers and are easier to treat. You also have medullary thyroid carcinoma, which is 1 in 10 cases. This can be hereditary. And anaplastic thyroid carcinoma, which is 1 in 50 cases. This is rare and with poor prognosis, affecting those aged 60 plus. So risk factors include thyroiditis, goiter, or family history of thyroid cancer, or radiation exposure, or previous radiotherapy, familial adenomatous polyposis, acromegaly, which is too much growth hormone, and obesity. About 9 in 10 thyroid cancer patients are alive within 5 years, with a large percentage cured with treatment paradigms below. However, only about 1 in 10 anaplastic thyroid carcinoma patients will live beyond 5 years. 1 in 4 patients are likely to develop metastases, where the cancer spreads to the lungs or bones, but these can be treated. So treatment includes surgery or thyroidectomy, radioactive iodine treatment, where you're swallowing radioactive substance that kills cancer cells as it travels through your bloodstream, external radiotherapy, which is radiation beams from a machine, chemotherapy, so the options include dacarbazine, vincristine, cyclophosphamide, doxorubicin, streptozotocin, fluorouracil, paclitaxel, and docetaxel. You can also have targeted therapies like cabozantinib, lenvatinib, or sorafenib. Clinical trials are recommended for patients with anaplastic thyroid carcinoma. So a case study begins with a 35-year-old Chinese male presented in an emergency room with goiter. He was unsure of exact duration. He had tachycardia, so heart rate over 100 BPM, and palpitations, which were on-off for a couple of months, but progressively worsening. There was no ophthalmopathy or dermopathy. He had no significant past medical history. A review of systems came back as negative for everything else. He did not take any over-the-counter or nutraceutical drugs. His social history was unremarkable. There was no family history of thyroid disease or autoimmune disorders. So we did labs, and his thyroid stimulating hormone, or TSH rate, was 0.01. His T3 was 744, and FT4 was 6.0. Thyroid stimulating immunoglobulin was not checked. The patient was presumptively diagnosed with Graves' disease and was discharged on methimazole and propranolol. The patient was taken off methimazole and a thyroid scan uptake was conducted. This showed a large thyroid gland with uniform uptake. The T2 uptake was 82% and 24-hour uptake was 81%. The patient went on to receive radioactive iodine, 131/29 MCI. The patient was subsequently found to have TSH of 8.7, T3 of 552, and FT4 of 0.99. He was asymptomatic. Methimazole and propranolol were stopped. The patient thereafter continued to remain asymptomatic. Here you can see the uptake of TSH levels in the graphs below, reaching up to 570. And here you can see TSH was normal and high. Here you can see the mild elevation in T3 below, slightly increasing. Here you can see the point when methimazole was stopped in the FT4 levels. So it stopped here, here was the result. Additional labs were checked with SHBG, which is sex hormone binding globulin, on the lower side, and thyroxine binding globulin, TBG, were found as normal. So SHBG result was 13, TBG 22.4, and these are reference ranges. This alpha subunit, which is helpful in distinguishing between this TSH secreting pituitary adenoma and thyroid hormone, was also in normal range, 0.6, and here is the reference range. A brain scan revealed an incidental pars intermedia cyst, which was not enhanced post-gadolinium. Here is the cyst, and there's no enhancement post-GAD. A T3 suppression test was conducted. So you can see the gold bar. And the FT4 graph can be seen below with the gold bar again signifying start of a suppression test. The T3 results are below. So you can see the increase here. The results are summarized below. Pre-T3 with 3.24, post-T3 0.13 in the TSH level, and the T3 level 167, increasing to 900 peak post-T3, and FT4 was 2.2 and reducing to 1.3. The SHBG was not elevated, the alpha subunit was normal, and there was no reduction in TSH by 96% with graded T3 dosing, but overall this was not consistent with TSH secretion tumor. A genetic analysis was conducted at the end of this testing process and discovered the patient was heterogeneous positive for the novel S350L variant in the THR beta gene. Here you can see the report, heterogeneous positive for the novel S350L variant in the THR gene. You can see the interpretation, resistance, and then explanation of the assay. All of this meant that the patient had an underlying resistance to thyroid hormones alongside Graves' disease. There was some degree of pituitary responsiveness with low but still measurable TSH in context of high elevated T3, T4 prior to treatment with iodine 131. Initial signs and symptoms pre-ablation suggest mild incomplete resistance in peripheral tissue. For post-radioablation, the TSH trending was up with T3-4 levels, and that was suggestive of overall generalized resistance, but below threshold at which the pituitary responsiveness was seen prior with high T3-T4 levels pre-ablation. Patient underwent a total thyroidectomy, which is the removal of the entire thyroid gland. This was performed after thorough preoperative evaluation with good ultrasonography and FNA. Preoperative planning was done to determine thyroidectomy versus